Hi, everybody. Welcome back. Let's hit it with chapter 14. This is talking about epidemiology. Let's get into it. Here are your learning outcomes. Once again, these are available on the notes themselves. So please review these if you would like to test yourself on these topics. Right. Epidemiology is the field of medicine that studies disease or adverse occurrences that are experienced by populations and basically the frequency of those things. So this also will allow for notification of health and disease officials whenever they need to accordingly. And they look for patterns in this stuff as well. So they often investigate things in terms of the who, what, where, when, and why of any occurrence of disease. So public health is any practice or activity designed to prevent disease or other negative outcomes in a community, country, or the world. This includes activities that promote health and wellness to try to keep disease down, essentially. Remember, disease isn't only caused by infectious things. It can also be caused by being overweight or obese, or having a genetic disorder or cancer. So that's not it, obviously. It's largely going to be informed. Public health stuff is informed by epidemiological studies and the look at disease within the populations again. So within the U.S., we have Centers for Disease Control and Prevention. It's the CDC, and that is what is responsible for protecting public health of the United States. They were involved in limiting COVID-19 pandemic. They're also involved in suicide prevention, maternal mortality rate in the perinatal period, chlamydia prevention, opioid use and detection in emergency rooms, anything that you might be concerned about to keeping track of within the population and its frequency in the population, they would be looking into. So first of all, we have Florence Nightingale. She was the first to collect public health information, essentially. She was a nurse, and she used her ability to identify patterns and statistics that allowed her to change medical practices. First, they had 32 out of 100 soldiers dying in the field hospital from dysentery, typically. Then she instituted changes that improved the unsanitary conditions of the hospital. And then now it turned into only 2 out of 100 died. So all she had to do was basically tell people to be clean. Next, we have John Snow. John Snow, he was looking in London, noticing neighborhood cholera outbreaks at the time. And this is a waterborne disease that is going to cause severe watery diarrhea. So he said that he thought that the cholera was coming from a specific pump, and he showed the cases around that pump, and then town council agreed to remove the pump's handle so people would stop stop using this friggin' pump and getting cholera and dying. Stop doing that. So so that was good. So now nobody was getting cholera anymore, and nobody was getting sick anymore. Look at this. I don't have my pen, and now I'm just trying to tell you to look at thing. This guy is great. Right, next we have, in the last 75 years, we established the CDC, obviously expanded to keep track of certain infectious diseases and certain non-infectious threats like insecticides or rodenticides that can be monitored. Then we have the Epidemic Intelligence Service in the CDC, where that's going to be looking at the outbreaks, essentially. After the use of antibiotics came around in the 40s, CDC was pushing for people to stop smoking. That's a bad habit that I engage in, unfortunately. Then we have the rise of antibiotic resistance and emerging diseases that are looking back at that now in modern day. So that includes the 2014 Ebola outbreak and obviously 2019 COVID. So this prevalence of disease is referring to the total number of existing cases. So prevalence, total number in the population. And then incidence, that's the number of new cases in a certain amount of time, okay? That you can also refer to as a case or a morbidity rate. So morbidity rate, the number of people over a certain amount of time that are getting sick, refers to the incidence of the disease. It's just a term for that. but it is the term that we'd be using for tracking in epidemiology situations at the CDC. Oh, right. Mortality rate. This is going to be measuring the number of deaths associated with the disease. Looking at these epidemic curves, you can, determine certain things. So we can also look at, use these curves and these outcomes and in an outbreak for determining, is this a point source epidemic or a common source epidemic, or is it, something else? So with a point source epidemic, a propagated epidemic, that's right. Okay. So point source epidemic, these are infectious agents coming from a single source, one source. All victims were exposed at the same time. Common source epidemic, we have one source, and then people were exposed over a period of time. And so we can look at curve patterns and determine if we think it is over time or all at once that these people were exposed. Propagated epidemic. This is from an infectious agent that is communicable from person to person and is propagated over time in a population, such as influenza, over time, continuing and having increases and decreases and such. So the index case is referring to the first patient found in an epidemiological investigation. Something that is endemic is something that has a steady frequency in that locale, in that population. Sporadic disease is referring to occasional outbreaks. That would include like rabies. So you would say that rabies is endemic maybe in the wild animal population, but in people, it's sporadic, right? Epidemic. This is referring to prevalence of something that would be endemic or sporadic, and that would be increasing beyond what's expected for that population. So if it was a whole bunch of people getting rabies and a whole bunch of people getting rabies, that could be an epidemic. However, if it's only, once in a while blue moon, that's just that normal sporadic occurrence. All right. So if you had a serious uptick of even something that would be considered endemic, then, that would be considered an epidemic as well, because it's that shift from the norm. We basically have an exact percentage that we need to meet in order to qualify as an epidemic, essentially. So I'm not going to worry about that necessarily, but that is a thing. Pandemic is a spread across continents. We know that that's the case with COVID. So epidemiologists think of diseases in spread of disease in 4 stages. So the susceptible host, the subclinical disease, the stage of the clinical disease, and then recovery, disability, or death. One of these things has to happen at the end, right? So that susceptible host stage, this is where somebody who has not yet encountered the agent or the circumstances that will result in an alteration in health. So you're susceptible, but you haven't gotten the thing yet. Second stage, subclinical disease. This is like incubation period, essentially. So it's a period of time after exposure where we're not seeing any damage. Third stage, clinical disease. Now we're seeing the symptoms. Yeah. Now from here on out, you can either recover, die, or remaining symptoms that we refer to as disability. Stick around with those symptoms, essentially. Okay, so detecting these diseases early is important, as much as we can detect them. Screening tests are designed to be non-invasive and particularly cheap and easy to perform to detect before symptoms occur. Okay, so before, so this is like a Pap smear. In case you didn't know, Pap smears are actually looking for HPV. FYI, so that's part of what they do. They look for abnormal cells and they look for the presence of HPV, which is the cause of cervical cancer. So they are deployed on healthy populations to try to detect the presence of the coming signs of a disease before it becomes an epidemic, right? These are different than diagnostic, because diagnostic are usually more invasive, more hazardous, and less patients are going to be likely to want to cooperate. They also have a lower accuracy. All right, so we're going to screen. We're going to try to find something before you get sick. So that is a Pap smear. So this is a screening test for cervical cancer. And then a biopsy, if you needed one after that, would be a diagnostic test, trying to actually diagnose that you do in fact have the cancer, or a colposcopy. That's another way to look at it. Okay, so screening tests as diagnosing tools. So you can potentially use these screening tests that are trying to look for the presence of these diseases before they break out and become serious, can use them as diagnosing tools in some cases, right? So that'll be for infectious diseases. And that can serve as our final diagnostic test in this case. So that's what we use for COVID. That's what we do with influenza rapid testing, and then a lot of sexually transmitted diseases that are associated with rapid testing. We can do that. It's important to understand the likelihood that the test will be accurate or inaccurate. In other words, positive, false positive, or a false negative, depending on which side of it. So that brings us to that concept of more likely to have false positives or more likely to have false negatives. So specificity is determined by how many people it will call positive who are actually negative. And sensitivity determines by how many people were positive were incorrectly found negative. So in other words, sensitivity, you're going to find all positives at the risk that some of those that you're calling positive might be negative. I don't know why I didn't just put a negative sign, but there you go. Specificity means that we are only finding or reacting with, whatever you want to look at it. Let's say finding, that's a better way to look at it. We're only finding positives, but you might miss a few. Here it's talking about false positives versus false negatives and what you would be trying to avoid necessarily. So with specificity, you're being so specific that you might miss positives every now and then because you don't want to get told that you're positive whenever, you don't want to get the positive, like if you're testing for like Ebola or something, you want only to know the positives maybe and not have it trigger that this person has this thing every single time. So that would be, in that case, something that we would call a false negative. Now, sensitivity, you're going to find all positives, but some of them are going to be negative and they're going to check as positives because you are just looking so much for any positives at all. Some of them might not actually be true positives. So those are false positives. So that's depends on what you're trying to eliminating. So that's what these are referring to. Eliminate these at the risk of the other one being a problem. Okay. Right, that clarifies that a little bit. Sensitivity, if it's super sensitive, it's going to get tripped off as being positive too easily. So you can always think of specificity as being kind of the other side of it. It's only going to bind with the positives, only those. But because it's so picky about it, some of them are going to get missed. Okay. Causality. This is the causative agent of a disease. We'll determine this using Koch's postulates, which we talked about in the last chapter, or certain molecular techniques like PCR, which is like molecular Koch's postulates. So the only way that a factor can be found to cause an outcome is to take a healthy subject, expose them to a factor, whatever that thing is, in this case, the pathogen, and see that it causes the effect. So that's the idea with Koch's postulates. Yes, you can't really test this on people. It's unethical. That's the problem. But they did, by the way. The Army has done plenty of that. So correlation and causation. Correlation is observed when one variable changes in the same direction as the other, but we can't necessarily say that it is the cause, right? Which is the cause. They're just necessarily happening at the same time. They're just a correlation. So in order to prove that, you want to perform experiments with control groups and everything like that, where you can compare, okay, this one that we didn't treat at all stayed this way. This one that we did treat turned this way, right? So we do animal studies for this. We also have randomized control trials. These are test exposures that might have positive effects as opposed to those that are potentially detrimental. So trying to look at things from a different light in a way. So this is the rationale behind drug trials. that will apply intervention to an experimental group that is potentially beneficial to them if the drug works. So cross-sectional studies, whenever we're doing these sorts of trials, these include two factors, the exposure and the disease. Those are collected at a single point in time and no reference to which might have occurred first. We're just doing them at the same time, looking at just those factors. Case control studies, this is a group of people categorized whether they have a condition or not. Then both are asked about certain exposures they've had to see if an exposure seems to occur more often in the diseased population, the group with the condition. Then we have cohort studies. This is where people with the condition are going to be enrolled and followed over time and monitored over time for the appearance of disease. I said they have the disease. That's not what I meant to say. People that do not have the condition, that's a cohort study, do not have the condition, are going to be followed over time to see if they get sick. We just follow them and see if they're going to end up getting sick and what the likelihood is and what they did, essentially. We can look at that as well, that caused them to become sick. So that's the cohort study. Hill's criteria refers to strength of association, consistency of association, specificity of association, temporality of association, and biological plausibility. So there's 5 things here. So strength of association, depending on statistical analyses, how strongly the exposure and the outcome are sometimes associated. Then we have consistency of that association when multiple studies of the same and different designs have the same result, that's consistent. Specificity of association, extent that one exposure is associated with the disease, or exposure only results in a single disease. So that's getting more specific there. So I hence called specificity of association. All right, temporality of association, the cause you're investigating of that disease can be shown to have occurred before the outcome, has to happen before it, right? Otherwise, this can't be the cause. Biological plausibility, that there are biological associations between exposure and the outcome that will reinforce the evidence that this is what's causing the outbreak or whatever. So then to surveillance. Surveillance is talking about collecting and analyzing data, essentially, of morbidity and mortality and transmission. It involves keeping data on a large number of diseases for public health reasons. And then notifiable disease are also known as reportable diseases. These are diseases that would be required by law that they be reported if you have a patient that was positive for these things. Reported diseases are usually highly contagious or dangerous or unusual. So when you were reporting, the physicians and hospitals will report all of the notifiable diseases that are brought to their attention. And depending on the disease, the reports are made either about individuals, like individual patients, or in aggregate. So when you have a group of people that are testing positive for something, depends on the disease. So government agency responsible is going to be the CDC, and they come out with the morbidity and mortality report for these diseases that are of concern. Okay, so healthcare associated infections are infections that you get associated with like staying in a hospital or a healthcare facility. CDC says 1 in 31 hospital patients and 1 in 43 nursing home residents will have a healthcare associated infection. So the top 4 are catheter associated urinary tract infections, central line associated bloodstream infections, surgical site infections, makes sense, and then ventilator associated events. All right, so in order to control these things, Medicare and Medicaid programs have stopped reimbursement to hospitals for these things that whenever you have patients acquired that are acquiring these things during hospital care. So they're not going to pay the hospital if your patient gets sick with these things. You don't get paid. Adoption of universal precaution, of course, is like questionable. I don't know how I feel about this. So adoption of universal precautions have been employed in, I think, every hospital ever. Medical asepsis, surgical asepsis, and infection control officers to make sure and monitor that we're not having any outbreaks of something at your location. So medical asepsis is hand washing, disinfection, sanitization, and patient isolation if they are infectious. Then we have a surgical asepsis. This is going to involve medical asepsis strategies, plus ensuring that surgical procedures are conducted under sterile conditions. Right, we would hope so. And then we have our infection control officer, and what are they going to do for us, and how they're going to be involved with tracking outbreaks in the hospital associated with that hospital, identifying breaches in asepsis. So you should be practicing aseptic technique surgically and everything. So if you're breaking that, that could be part of the reason why people are getting hospital or healthcare associated infections. And then also training people on working with proper aseptic techniques. So that's what this person's going to be involved with. So that brings us to the concept of the reproducibility rate and case fatality rate. So the reproducibility rate, or R naught, or R sub zero, I usually call it R naught. This is a term that is given to basic reproduction rate of an illness, a pathogen. So it's how many people, so it's essentially the spread of that illness, okay? So how many susceptible people on average that one infected person will spread it to. That's what that's a measure of. If I'm sick with COVID, how likely, on average for COVID, is it that I'm going to get a certain number of people sick? So that would be the R naught, that number there. So if people in general are, when they are sick with COVID, likely to get 3 other people sick, then 3 would be the R naught. So you can't always determine this right off the bat, right? You sometimes need to have a little time to determine how infectious this thing is. So this is assuming, when we're calculating the R naught, that exposed individuals have no secondary immunity against that microbe, that they haven't seen it before if they've been exposed. Okay. Case fatality rate. This is the number of people who die of the disease, if they get it, basically, by the number of persons infected. So this is based on people who receive no treatment at all. So R naught and case fatality rate. This is going to be based on geographic location. Of course, healthcare might be better in one area than another, especially if we're talking about a third world country versus a first world country. And then the case fatality rate, right, circumstances of the outbreak, how it's coming about, variant of that microbe. Some of them are worse than others, of course. And then vaccinations are going to be needed in order to control infections that have high R naught rates, like measles has a high R naught rate. Okay, so this is talking about the case fatality rate and the basic reproduction rate as well. So this is the R naught over here, the communicability. So these are things that would be extremely communicable, high R naught rates. This is measles, this is malaria, this is mumps, rotavirus, pertussis. Rotavirus is a virus that causes diarrhea. It's typical diarrhea. So those are extremely communicable. And then we have a very communicable, which of course you might think of chickenpox as highly communicable. And then things that are just communicable. I would like to point out that TB, which we talk about a lot in the class, is in that communicable section, along with rhinovirus, because of the common cold, one of the causes of the common cold. So think about that. And then we have the minimally communicable diseases. So you want to consider that along with how fatal the disease is. So if we look here, measles is down here on the not very fatal area. So you might not be as concerned about that. When you look up here at tuberculosis, now look at that. There's tuberculosis again, and the plague and Ebola. We've put tuberculosis in with the Ebola and the plague, by the way. And it is in the communicable section. I'd like to point that out one more time. Right, and we know smallpox and polio were highly communicable. So and rabies, super deadly. Rabies is 100% fatal. I don't know if I've said it, but if I said it once, I can't say it enough. Rabies, 100% fatal. If you are bitten by a dog that has rabies, you have approximately 2 months, typically less than that, in order to get your shots. If you don't go get your shots, your immune globulin, which is extra immune response against the thing, up ahead of time, and then the actual vaccine, if you don't go get those as soon as possible, and you start developing symptoms from rabies, the typical like agitation and stuff like that, hydrophobia, you can't swallow water and everything, you're done. 100%. Not anybody, nobody will survive it. So it's 100% fatality if you start showing symptoms. The only way to deal with it is post-exposure prophylaxis. Rabies is no joke. And HIV, if we just let you go and don't treat it, this is what this is talking about with the case fatality rate. If we let you go and do not treat it, yeah, you dying. That's just how that goes. Super dangerous. They put it above Ebola and the plague, guys. So next we have the R naught during the COVID pandemic. It was difficult to calculate because it was a pandemic that was in process and it was a brand new virus, right? Early on, we thought maybe 2 to 5 was the R naught. Delta seems to be about 3 to 5 now. Omicron is about 5. So you're, if you get sick with COVID, it seems like you're going to infect about 3 to 5 people basically while you're sick. It's likely that you will. So think about that next time you're sick and you're thinking you're going to go out and grab something to do whatever. Don't do. So vaccines. Vaccines are important in controlling infectious diseases as well as being involved in herd immunity. This means, so herd immunity is whenever we have a whole lot of people protected and are immune to that infectious disease to limit the spread so that people who cannot get vaccinated or aren't vaccinated for some reason, their ability to be protected by everybody else being vaccinated. This is different for every disease, and it depends heavily on that R naught that in order to determine how effective that has to be. So 95% of people have to be vaccinated for measles in order for it to confer herd immunity. That means that 95% of the population has to be vaccinated in order for the other 5% to be protected. Those 5% really should only be people who cannot receive the vaccine for some reason. They have immune issues, they are a little tiny baby, or whatever it is. And, you know, into that. I'll get on the soapbox again later, I'm sure. So, so vaccines and herd immunity. So that's how that's going to be working. That is assuming that those who are not immune, haven't been vaccinated, are going to be indirectly protected by those who have been vaccinated, because ongoing disease presence within that population is going to be small because the other people are vaccinated. So this is going to be achieved from people who have either survived the disease or have been vaccinated. So vaccines, so you can be surviving the disease, right? So there is that. Vaccines will go through several layers and trials before they are administered. It's not like they just out and gave you some chemical out of nothing. All right, so herd immunity and no herd immunity. This is just depicting pretty much exactly what I was showing you guys. This person comes along. He gets infected with coronavirus. He was not safe. And the immunized people don't get sick. So the immunized people can't pass it on to the non-immunized people, and you're not getting enough contact with them when you are a sick person. So you get over it. You have naturally immune because you were exposed to the sickness. And these people are still not immunized, but they're still healthy because there were enough people that were immunized to protect them from having to come into contact with this virus while it was present within their population via that infected person. So that's the idea of how that works. As far as no immunity would go, then you were talking about people have to get sick in order to actually become immune to the virus. They have to get sick. So it's going to get spread really easily, especially at first, and then you're risking people dying of these diseases. And don't think that measles is some joke. There are plenty of people that die from measles. Of course, there's other diseases too. So, you know, that's that. So this is just talking about what's involved in the approval in the approval of vaccines. You know, I've worked in a lot of this industry and research and everything like that. So I'm well aware of all this stuff. So I'm not going to go over this detail with you. This is more for interest for you guys. If you are interested, again, these are always available in your textbook as well as in your notes. So for the COVID-19 vaccines, we know that was in about 2020. Approval processes were sped up. So because there was a pandemic, so we needed to speed it up, but there were no shortcuts taken. We used mRNA technology. This is that messenger RNA. And we've talked about this previously with COVID. Essentially, I inject that messenger RNA into your arm, your muscle cells start making that viral protein. Your body starts reacting to that foreign viral protein that's on your muscle cells. And it develops antibodies. And the next time that you see COVID, you are protected because you've already seen that protein before. So that's the idea of how that would work. So phase 3 was started before we finished phase 2, but we did actually go through them. So that's kind of where they jumped ahead. So they have studied the effects of the vaccines. That's called what they call sometimes phase 4. So that we know that there's some issues with that. I had that COVID arm or whatever, where I got the vaccine and I got like that huge rash all over my entire arm. And I don't know that I was fine the second shot. So vaccine adverse effects reporting system is what you would contact if you were having adverse effects. You could do that through your doctor, of course, as well. You make a report, whether that adverse effect is related to the vaccine or not. They will still want to report it so that they can see if there is a causative situation due to that correlation. So patients, parents, and healthcare providers can call and contact to report that. Vaccine injury compensation program is just saying that there are situations where you can get paid money if you do have a lasting adverse effect from a vaccine, having received a vaccine, because unfortunately this does happen. That's the risk that we take when we're trying to establish safety for the population. We can't predict that this is going to be the case for people, unfortunately. So anyways, what they're saying is a lot of times if you do have a lasting effect from a vaccine, you can sue essentially, and plaintiffs so you can win money as a plaintiff. And when you are a plaintiff, you may not even have to pay attorney or court fees at all. So that is what the vaccine injury compensation program would do for you if you did have vaccine injury. All right, so global issues, we have increases in infectious diseases. These are emergent diseases that are new identified microbes. This includes COVID, of course, that's a new, and then novel strains of influenza, and all SARS really is pretty new. So we can consider that. So every time we have a new strain of flu, that's an emerging disease. Overall, not that emerging. So re-emerging diseases, these are diseases that affected us in the past, but are becoming more prevalent again due to travel or something like that. So the Global Disease Detection Service is a collaboration between the CDC and the World Health Organization. We want to monitor emergence of epidemics and diseases. So CDC also looks at developing situations in health and disease and may or may not be associated with infection. And there are strategies they may create as a result to decrease morbidity and mortality of those situations. There are also, we need to remember, we don't have these in the United States, but we need to be aware that these exist in less fortunate situations. So people who may not be as wealthy as the typical person might be in the United States. Now we're talking about third world countries. We're talking about underdeveloped countries or undeveloped countries, that they have the incidence of these parasitic infections. Not all of these are going to be that sort of situation. Some of these we have in the United States. So get ready for that. So the CDC has begun a campaign against parasitic infections in general in the United States. So these are, of course, more common in poor neighborhoods and immigrants. So this includes Chagas disease. Chagas disease is mostly in the southern portion of the United States. It's transmitted by the kissing bug that's caused by the protozoan Trypanosoma cruzi. Next, we have neurocysticercosis. That's going to be a tapeworm that got into your brain. Toxocariasis. This is worms that travel into the tissues and then all the way through the tissues and then into the eyes and cause blindness. Then we have a toxoplasmosis, toxoplasma. This is a protozoan that are Toxoplasma gondii. It's an important one. It's a protozoan, affects 60 million people in the United States. It's a huge proportion of people in the United States that have been exposed to this at some point in their life. Massive amount of people have been exposed to this at some point in their life. This is just in cat litter. So if you handled cat litter, you probably got it. So it does increase risk-taking behavior and also slows your response times, which is great for cats that are trying to hunt for mice when the mice are sick. And the reservoir is in cats, but we get it from our cats, and it can cause serious complications in a fetus if you are pregnant. So do not handle cat litter if you are pregnant. I'm serious. yeah, and it's really, really bad for people with immune system problems. We can talk about Trainspotting if you'd like to at some point, but that is a movie that has that in it. Okay, trichomoniasis. Trichomonas is a protozoan that's going to affect the genital tract. It leaves those infected more vulnerable to other sexually transmitted diseases. So if you have trich, then you are more likely to get infected with some other sort of STI. Okay. It can also lead to apparently premature births in infected mothers. So that's a bad thing as well. So here, this is talking about, we'd want to bring up bioterrorism, of course, because we talk a little bit about anthrax. Let's bring up anthrax here. Spread of anthrax in 2001, and there was a bioterror event in, I think, the Senate or something like that, that released anthrax, in the powder form. So endospores, they're endospores, forms endospores. Anyways, that's that. When we know there's an issue always at all times, international or threatened use of microorganisms or toxins living organisms to cause death or disease intentionally in humans, livestock, or plants. That's what bioterrorism is. So using these microbes and their toxicity potentially to hurt or harm people. There's always a concern that perhaps we might see reintroduction of smallpox, for example. So that would be a concern for bioterrorism. Then there's agroterrorism, which just means decimating huge amounts of the agricultural industry using maybe viruses that infect the plants and kill off a lot of plants, or even viruses that will cause abortive effects in cattle, like Rift Valley fever does. So those are examples that could be very, very detrimental to the United States, and that's called agroterrorism. So it's agricultural, not like video games. Okay. All right. The question of this chapter is, what is the difference between point source epidemic and a common source epidemic, and why do we care? So I'm going to leave you with that, and I will see you guys for the next time.